Welcome to Conversations on Healthcare. This week, we're turning the tables as we mark a half century of the first free community clinic in Connecticut. Veteran journalist Thalia Assuras interviews host Mark Masselli and Margaret Flinter on their 50 years of transforming community care. Now, here's our guest host, Thalia Assuras.
Hello and welcome to Conversations on Healthcare. Don't worry, as you see, your longtime hosts, Mark Masselli and Margaret Flinter, are here for what is a special edition. Special because we are marking the 50th anniversary of Community Health Center Incorporated, and also celebrating this very show that these two created. As you know, CHC is a nonprofit based in Connecticut, has offices in Colorado and California, and programs right across the country through its Weitzman Institute. So let us begin after 50 years already. Congratulations, Mark. Let's start with you. Thank you to both of you for letting me sit in your chairs. Mark, you founded CHC Inc. in 1972 when you were barely out of your teens, and that's significant. What motivated you?
Well, first of all, thanks so much, Thalia, for turning the tables on us. So we're in the hot seat, but we look forward to the conversation. You know, it was a great opportunity that I was presented back in the early 70s, an opportunity to work with other young people. And we were setting up a drop-in center, a 24-hour crisis hotline for young people who were facing all sorts of problems and difficulties. They were running away from home. There was issues around drug use and abuse. And there was just a wide range of issues. And, you know, it was a real opportunity to hear people directly talk about the challenges they faced. And it turned out that the common theme, whether it was a runaway or someone on the crisis line or somebody who just walked in with a problem, that access to healthcare connected all of them. They simply didn't have access to affordable and quality and comprehensive healthcare. So come 1972, I had heard about a conference that was being held in Washington, D.C. by a group from California, from the Haight-Ashbury Free Clinic. And it was going to be hosted by them in Washington in January of 1972, and I made my way there. And, you know, it really was just an exhilarating time to hear the voices of people who would become friends from Boston to LA, who were thinking about the same thing that I was thinking about. How do we solve this healthcare problem for people who we're engaged with? And we heard from people who, like us, who were just thinking about setting up a health center, to people who are running free clinics around the country. And I think from that day to this day, it has animated all the work that I do and that Margaret does in terms of trying to build a system. And you know, there were enormous challenges along the way. I think it's fair to say pretty naive about what it took to get a free clinic going, but we found our way to a second floor walk-up in the building that we were in. It was sort of a ramshackle apartment building, but we made the best out of a second floor apartment. And you know, you could have been in San Francisco. It had tie-dye on the walls. There were beaded curtains that separated the rooms, and that slight scent of incense was in the air all of the time. And, you know, we opened up, and the great news was that we found some local dentists who said they wanted to volunteer. And so I reached out to the Christian Dental Association. They donated a chair. Friends at Wesleyan got their physical plant to install the dental chair in the kitchen. And we converted the bedrooms into 2 exam rooms, and we opened the door. And that was exhilarating. But back to the naivete. A few months later, got a knock on the door, answered it, and they said, "We're from the state health department. Where's your license?" We need a license?
Right. One of several challenges all along the way, I'm sure. And you mentioned tie-dye. I mentioned that you started this just out of your teens. I bet you were wearing tie-dye shirts yourself. But that's another story. That's another story. But you really started chair by chair, really, street by street, if I could almost put it that way. And you talk about challenges all along the way. There were several, but what do you think are the biggest challenges you faced and how you overcame them over the 50 years?
Yeah, I think the biggest challenge is trying to find resilience when crises arise, right? Because they're bound to. Our being shut down by the state of Connecticut because our hallways were 1 inch too narrow when that inspector came in. Most of our volunteers left. Didn't seem like there'd be a possibility of doing this work that they wanted to do. And I think that's always been the case. There's a setback that you have when you're knocked down, that you need to get back up. You need to find your resilience, and you need to propel forward. And I think that's been a common theme. And I would just say to everybody who's doing anything, that you're bound to find that there are that heady moment when, for us, when we opened the free clinic, to that moment of despair when we got closed down. You have to find sort of some equilibrium amongst all of those and not get too high over the excitement of something or too low in the despair of a setback.
Right. Equilibrium is a key word there. And Margaret, I'd like to bring you in now too. I mentioned the Weizmann Institute, which you spearheaded. You're also a nurse practitioner, and you've expanded the profession itself through CHC Inc. What inspired you to actually team up and stay with this CHC Inc. for more than 40 years?
Yeah. Well, thanks. And thank you, Thalia, for joining us today. I was a few more years out of my teens than Mark, but not much. I think I was probably 27 when I arrived, a newly minted nurse practitioner from the Yale School of Nursing, although I'd practiced as a public health nurse and critical care nurse for a few years before I arrived here. My choice of the health center was somewhat both pragmatic and fortuitous. I was a National Health Service Corps scholar, obligated scholar, as we used to say, meaning I had a period of service commitment in exchange for the federal government graciously funding my time at Yale. But I had a choice, and I visited around New England and a number of community health centers. And I say about my first meeting with Mark, my first visit to Middletown, I had found my people. It was really clear to me, this banner of healthcare as a right and not a privilege, this model of a community health center that made healthcare available to people regardless of their finances, and not just any healthcare, but a kind of healthcare not available to the wealthiest people in America, fully integrated, even in that one hallway that existed. After the second floor walk up, we were on the first floor hallway on Main Street, but it was really the original idea of a community-based, patient-centered primary care home. There was only one of each of us, a dentist, a doctor, a nurse practitioner, a medical assistant. We didn't have our first RN, I think at that time, a parent aide who went out into the community and worked with families that were struggling, a social worker, and of course, somebody to sort of take care of the finances and the data, and Mark in the leadership position. But that model would give rise over the next 50 years to what has been pretty universally acknowledged as this is the model of what really good comprehensive primary care ought to be. Not yet fully realized for everybody in the United States, but it was the first step on a long journey that feels like it's just been overnight.
Well, let's backtrack a bit, and Mark, I'll come back to you because the vision, the mission, and who you serve. Can you give us just a quick overview?
Sure. I mean, I think the mission, vision, values have always been that healthcare is a right and not a privilege. I think it animates so much of the conversations that we have even today with young people who hear that. It's something that courses through their veins as well. The population we care for, we're in 243 locations here in Connecticut. We're in 34 farms, so we're taking care of farm workers. We're in 10 homeless shelters, taking care of people who simply can't find affordable and quality housing. We're in 185 school-based health centers, taking care of young people from elementary school all the way through high school. And then we provide 16 fixed primary care sites, large sites across the state of Connecticut. It's mostly people who live in poverty, a very diverse population. Probably 95% of our population, and we care for around 150,000 patients, are at 200% of poverty and below. But it's really, we run a battered women's shelter. We're engaged in so many different activities that touch so many different lives, from gender affirming care all the way over to primary prenatal care. We are fairly diverse in terms of our population. I would say it's a very diverse population. It's also one where English is not always the first language spoken, and we probably speak 50 different languages a month. Here at the health center, we've got a great translation service. So we're seeing, from single individuals to large families.
Enormous, actually. It's a diverse population and large. And Margaret, not only are you serving the communities, you are helping the people you serve, who serve the communities. Why has that been important? And you've been involved in that very deeply, haven't you?
Sure. Well, we need the next generation always of people who will provide the healthcare, and we need to support the people who are doing it today. And over the years, I think we've recognized that our partnerships with academic universities and training institutions are so important, and we've welcomed in and continue to welcome in from many universities and colleges. I think at any given time, we have 300 students and trainees within the organization. But we also recognize that there are elements that the service delivery-based organization can provide as key educational learning experiences that can never be provided in the classroom. And so we've taken on not just providing clinical experiences to students, but we've also developed our own de novo, tailored, accredited, rigorous training programs along the continuum for medical assistants. I hope we get to talk a little bit about that, an idea whose time had come in terms of a new way of training medical assistants who are so critical on that healthcare team. We developed the model of postgraduate residency and fellowship training for new nurse practitioners to ensure that they had the same opportunities that other health professions have had of a solid period of time, in this case a year, to be fully embedded in the primary care setting, working as part of a team, taking on the most complex and challenging patients that we see, but with the support and mentorship of expert clinicians as a way to, if you will, fortify them for long-term careers in community health centers. In the public's eye, I think sometimes primary care is about the simple, the easy, and the quick. I have the idea of the convenience clinics or the walk-in center. But primary care in a community health center is about a commitment over time to people who are struggling with challenges that most of us never encounter in our lives, financial, social, and often clinical. When people don't have resources, it's often because of compounding physical and mental and emotional difficulties. And so they bring all that to bear into the setting, and we owe it to that next generation to train them with real optimism and purpose. And that gave rise to postdoctoral clinical psychology residencies, to a full pipeline for the behavioral health professionals of nursing students, and much more to come. Dentists are well represented in that as well.
Well, you wanted to talk a little bit more about medical assistants. Why? Just very quickly.
They're a group, I think, that represent the people that maybe Mark and I have the softest spot for, right? The people who've grown up in families, who've worked hard, haven't had much in the way of resources. And often we could see that very bright and talented people, maybe the guidance counselors didn't work with them so much about plotting out an academic career post-high school, or maybe there was an imperative to get to work right away. medical assisting has long been a first rung. It's a certificate-based program. It doesn't require an academic degree, and something sought after by hardworking people looking to do good in their community. Too often finding it only available through for-profit institutions with pretty extreme tuition that then put them in debt for many years following their education, and didn't give them clinical experience in that kind of high-performing, highly mentored setting that we just talked about. We thought we could do better by those individuals who are often people in our own community, and we would see them in interviews. And Mark really led the development of the National Institute for Medical Assistant Advancement, which I think has kind of turned medical assistant education on its ear a bit in a positive way, and now operates nationally around the country and has graduated several classes, really on its way to becoming a powerhouse of training, often that first generation in families to go on for post-high school education and training, and a first rung in the healthcare professions.
If I can just add some to that, I think Margaret was spot on. The indebtedness that we see that happens through this training. So just understand that people pay between $30,000 and sometimes $40,000 for 7 or 8 month training. That's a little more than if you annualize it out, maybe for Harvard or NYU, or that for simply a certificate. We find them 15 years later still paying off that debt. We needed to find an affordable way of doing that. And as Margaret said, the classic training program is seven months in an academic setting, and then a month where they have to go and find a placement. And we really turn that on its head by embedding the student for the entire 8 months in a primary care setting. It's a great job opportunity interview that extends over a period of time, really binds people. And, we want people like we found our people to find their people. And the only way to do that is by this collaboration that we've developed. But we are very focused in on trying to transform the entire educational system in terms of that entry level, whether we're running our community health worker program, our various training programs. We're very concerned about that entry level. We want people to have a unique experience and opportunity.
And the people who come to the various centers, your various clinics, a question for both of you. And Margaret, I guess I'll start with you. Is there one person or one family who remains seared in your memory and says to you, this is why I'm doing this?
Thousands, not one, really, truly thousands. And I think one of the amazing elements of being in primary care, and I think this is true of primary care providers generally, it's just so much larger. I think at the health center is that people and families over time. So there are the pivotal moments that are seared in your mind, a tough diagnosis, a family crisis, a great success in a family. And then there's just the evolution over time. And so, Mark, I think you probably have the same experience. Some of that is realized walking down the street when people call out to us, and remember me from years ago. Maybe that they've just returned to the street in Middletown, and maybe they're back visiting family for the holidays. I hear regularly from people that I took care of decades ago who will, look you up on Facebook and say, do you remember me? You took care of me when I was, a kid, a teenager, whatever. But I think there are also the people and the families who are seared in our mind because what happened to them should never have happened to them. And they became, for me, I will say, part of the galvanizing force to create change. And I can think of so many of those really that inspire me, particularly around the areas of women's health, women's rights, domestic violence, substance use disorder, what happens to people in the criminal justice system. I have stories for all of those that are attached to crystal clear images in my mind of the people that they were that was their story. And I think for everybody at the health center, they have those experiences that really, on the toughest days, propel you forward because we use those to create lasting systemic change. And we have the opportunity at our size and our strength to influence policy and practice in the United States.
I can only imagine. And Mark, a significant memory for you?
Yeah, I'm not a clinician, but one of the unique things that we did when we were starting the health center was that we said we're going to organize ourselves at our board in a different way, and that we're going to have the majority of our board members be patients. And that's unique. Oftentimes we have people just saying, how's that possible? These are people who live in poverty, they're not capable. And the reality is they make do with less. They live in poverty and they're raising children, they're feeding families, they're going to work, they're hardworking, and they're problem solvers, because you have to be a problem solver where you don't have a little money. One of the early board members and who was a mentor to me was Reba Moses. So Reba grew up born in 1920s in Pimlico, South Carolina, just a little outside of Florence. Her dad was a sharecropper. She found her way in the 1940s as part of that great migration of African Americans in the South. She found her way to Middletown, and she raised this incredible family, 5 kids. And she was a foot soldier in the civil rights and the anti-poverty work that was going on at that time. And she found me as a young upstart. She was probably close to 30 years older than I was, but she became a friend, a mentor. She served on our board of directors, and she is emblematic of so many people that Margaret and I get to work with on our board who are patients, who come here and then they guide us and made such a profound impact. And Reba, we've named the Lillian Moses Child Guidance Center. So there are many people like that who course through the history of the health center, who are patients, and whether they're a clinical experience that they have or in a leadership role in the health center, they've made us who we are today.
Yeah.
Thalia,
if I could just add on to that, one of the remarkable experiences that's begun to happen more in recent years, particularly with the training programs, the residencies and fellowships, as we interview people, is how often at some point, and often not in the original interview, may not be revealed until later on, people tell us that they used either this community health center or a community health center somewhere in the country as children, often children in immigrant families that did not speak the language, where there was such fear and concern about all the challenges they faced. And they speak of how in their family, they heard their parents saying that the health center was the place they could trust, that was the place that they could go for help, and that their experience of a health center, of getting care in a health center, really fueled and propelled them into the health professions down the road. And we have a few of those people on staff here at the Community Health Center today, and it's a very special thing to realize the impact the experience of receiving care in a health center like this can have on the future life of a child.
I have to challenge you just a little bit too, as we should challenge everyone. Margaret, I'll stay with you. But I'd like to talk about the advances in caring for the underserved. You mentioned some of them, but where have there been failures too?
Mm-hmm. Well, I don't think, maybe I'll start and Mark just jump in. Good news, right? The Affordable Care Act came along in 2010. We had all, we were excited in the 90s that maybe Clinton reform would come. We were worried in the 80s that block grant funds would take it all away. There's been lots of policy changes over the years. The Affordable Care Act did some very powerful, significant, and sustained improvements. And I won't go into all of it, but suffice it to say, there are a whole lot of people who had not had health insurance in decades who received health insurance, and a whole lot of families. And we need to continue to build upon that to make it even better and stronger, but it's certainly done some great things. I think the biggest shortcoming is the failure to have absolutely universal access to healthcare, to control the prices downstream, because we don't do everything in primary care, but to control prices downstream, particularly around things like pharmacy. But the third has been around the model of care itself. And I'll just say two things about that. One of the big ones, it's hard to say thanks to COVID, but thanks to COVID, one of the big ones that a 15, 20-year overdue major addition of virtual care to the armamentarium of people in healthcare actually came to pass. And we all did it kind of overnight. And now we have to do the hard work of research and evaluation and testing to see what really works best. But that's been a huge plus. What hasn't happened is we haven't recognized that as long as we're locked in this 100% mostly fee-for-service system, there will always be a bit of the rabbit wheel of running to do more visits, which means less time with patients and more focus on the episodes than the care overall. And that there's certainly a lot of people thinking about it, studying it, researching it, but we still haven't seen that transition, although there's baby steps towards it. So full 100% access, more for the people who need more. As we say in our health equity work, it's not about providing the same thing to everybody, it's providing what people need, which may be much more in some cases, removing those financial barriers, but then really making sure that we have the time and the model of care with full integration of behavioral health, oral health, as well as medical services into primary care. That would be a good start.
Yeah, and Mark, if you would pick up on that, it's impossible to separate healthcare for in this country from how we actually pay for healthcare. And you've been through those budget battles in Washington for, trying to help your construct in what are called, and maybe people at home don't know this, they're called federally qualified health centers. You've been fighting those battles for these centers across the U.S. What have you learned, and what are you looking for further?
Well, and I want to pick up a little on the last question because I think it's important. This is a white system. I won't say it's a racist system. I think we've maybe evolved a little, but it is a very much focused in on not on the population that we care for, right? None of the research has been done in terms of health outcomes until very recently, and only in very small steps have we researched the health conditions of African Americans, of Hispanics, of Native people, and this is to the detriment of the health and well-being of tens of millions, 100 million Americans who've been left out of the entire healthcare system. It has been designed to limit the health, the opportunities that the rest of us have. And so I think that's an enormous shortcoming. We do not have, until very recently, an equity lens on the healthcare system. And when we put that lens on, we see how far it has fallen short in terms of delivering on the promise that we have articulated, that healthcare is a right, not a privilege. We often say there's access, but what is there access to, right? Well, it's care that has been designed for populations that really are not the population that we're seeing. And so I really worry that we're making progress, but it's too slow. It's been late in so many cases. We simply haven't done all of the research. If you think about all the research that has been done in healthcare, has been done on a sort of a white male population, maybe a white female population, but really no diversity at all, and that's limited. So I think that's the biggest challenge. I will add to that the paucity of providers, African-American providers, Latino providers that really need to be front and center in the movement. As to the federally qualified health centers, who all have been fighting, I think, not just us, but fighting this battle to make sure that there's equity across the spectrum. I think the one thing I come away with it, and I think one of the brilliant things, and I give a shout out to Ted Kennedy and maybe somebody like an Orrin Hatch who just passed away.
Absolutely.
Health centers found common ground on both sides of the aisle. That is the only way we can move forward. There is too much extremism that has been dominating the way that programs get funded. health centers back in the late 60s and early 70s realized that we needed to find this common ground. And so we had leaders like Ted Kennedy and Orrin Hatch who stood together, who were ideologically so far apart, it's hard to describe. But they said, funding community health centers makes sense. They have this sense of local community control where patients are engaged in that. They're serving these neighborhoods for whom no one else would go to. And whether you're in Kentucky or whether you're in Boston, Massachusetts, they're making a profound difference. So while there are enormous struggles in terms of rallying support for them, there's enormous hope that this model actually, and I think it has built this incredible network all across America, 1,400 community health centers, tens of billions of dollars invested in them. And that all comes about because there was common ground.
Let's hope that sense of compromise and civility you were talking about, Ted Kennedy and Orrin Hatch, will come back. It's one of the problems, the current problems. But I won't get into the politics. I won't do that. Well, there's so much more to talk about. So let's continue this discussion next week on Conversations on Healthcare with Community Health Centers, Mark Masselli and Margaret Flinter.